My talk is about the atrial flow regulator in small children, and it is for now a completely off-label indication. But there is a long story about this atrial flow regulator. So first of all, this device is primarily designed for adults, but in fact, the story is really starting in children, in babies. So, for example, we have a condition called the Luttenbacher syndrome, where that combines usually rheumatic mitral disease and an atrial septal defect. And in this type of patient, the defect often improves symptoms. In babies, we know, as pediatric interventionists, that we sometimes have to stent the interatrial septum to relieve left atrial hypertension. So really, the target in some patients in cardiac failure is to target the left atrial pressure when it is too high. And indeed, in adults, sometimes when they have the association of atrial septal defect and left ventricle diastolic dysfunction with elevated, potentially elevated filling pressure, then closing the ESD may put them in pulmonary edema. So in order to address this, there are three types of devices, and I'm going to mainly talk about the Occlutech AFR device. But I would like also to start the story of this concept of having a septostomy. So the septostomy has been first performed just by balloon, and there was a very famous interventionist in Mexico, Sandoval, who published in the Journal of the American College of Cardiology in 1995 one of the pioneering experiences to do septostomy in patients with pulmonary hypertension. But unfortunately, in 1/3 of the case, after a few months, the defect was closing spontaneously. And then for babies, for children, when we had, I was involved in children with pulmonary hypertension in my previous institution in Marseille. And I was wondering, I mean, you don't want to go every 3 months to do a septostomy, a CAT intervention in the children. So I was looking for a device. And then I discussed during one of the meetings with Professor Zaid Amin, who is here. And he told me he was using this fenestrated atrial device that was made especially for him by Kurt Amplatz to maintain open the Fontan fenestration. And I think at this time you had done 4 cases, Zaid. And then I got inspired about that, and I decided to speak with, I got in touch with Kurt Amplatz to ask him to make a fenestrated device like that. And he sent me this device, we were in 2002, 2003. And it basically worked very well. And he sent me 2 devices. I implanted one in this 3-year-old with family pulmonary hypertension who was having syncope. And this patient, for this patient, it worked very well. First of all, the fenestration remained patent for more than 10 years, despite it was only a 4mm hole. Secondly, the patient improved with epoprostenol, and she basically went very well until 13-year-old, when she decided to stop the epoprostenol. She had a kind of teenager crisis, and unfortunately she said, I don't want any more central line, I want to stop the epoprostenol. And then she started to deteriorate. She had a successful heart and lung transplant in Marseille at the age of 18, and unfortunately she passed away a couple of years later after, but she survived basically with this type of aggressive management until adult age, which for this condition is not too bad. So one of the interesting thing, and I will comment on this later, for some reason I cannot run the video. We could run it before, but I cannot run it. Anyway, we'll see that later. And so this is the device. And I remember very well Zaid telling me, you need to put a wire because sometimes you need to dilate the fenestration. You remember that probably, Zaid. And in fact, that's what I did. But I think for pediatric patients, it is not always necessary, certainly for Fontan fenestration, but I will come to that a bit later when I will address the AFR. So I published this case a few years later, and I think it was really the beginning of the history of having a fenestrated device in children. So in adults, there are much more patients with cardiac failure with or without preserved ejection fraction, and the technique is to do a transseptal puncture. It is recommended to avoid, if there is a PFO, it is recommended to avoid crossing the PFO and using the PFO as a route, because then you end up with a kind of oblique implantation, and sometimes it may you may have an unstable device position, and also you have an oblique position, so maybe it is more risky with a spontaneous closure. Then you position a stiff wire in left upper pulmonary vein, and it is recommended to balloon dilate the septostomy 4 to 6 millimeter larger than the intended fenestration. So, for example, if you want to implant an 8 millimeter AFR, 21H, you need to balloon dilate probably with a 12 or a 14 millimeter balloon. And then you just position the device just like you would close any ASD or PFO, one disc on the left atrium and one on the right atrium. The criteria of inclusion in adults are well defined. The cutoff is a wedge pressure at 15, above 15 millimeter of mercury. And the PRELIEF study was the first study to assess this AFR in adults. And there were 53 symptomatic patients. There was one device embolization, one serious adverse event with bleeding. And the result at 3 months was quite encouraging because there was clear hemodynamic improvement, no worsening symptoms, and some patients even improved. One of the criteria also is the septal thickness, because the AFR is is also a little bit thick, with a height between, you have either 5 millimeter or 10 millimeter height. And then, depending of the thickness of the septum in an adult, you need to choose one or the other. But then, for a baby or for a pediatric patient, this is different. Having a 10 millimeter height, you may end up with a quite unstable device. So, in Europe, Gianfranco Butera and Enrico Piccinelli, they have set up the European registry, especially in failing phantom, but also in patients with pulmonary hypertension, in children with heart failure, just like in the adults, and of course when they are on ECMO, to create a pop-off during the ECMO. And there are technical specificity in small children. First of all, we have used PFO without any problem because the septum is much more flexible than in adults. Pre-dilatation of the septostomy is probably not needed. We have implanted in a few patients the AFR without dilating, except if the septum looks very thick. The delivery sheet of the Occlutech, it's important, it can be undersized 1 to 2 French. And this is important because that means that if you want to implant in a small baby 6 millimeter AFR, which goes into a 10 French, you can, and I guarantee you can go to the 8 French without any problem. I wonder if you could even take a 7 French, but 8 French, 100% without any problem. And then, similarly, if you want to implant a 10 millimeter, instead of taking a 12 French, you can take a 10 French. And then you can think about small babies. Let's take a 3 or 4 kilo babies. You want to implant a 4 millimeter AFR. Instead of an 8 French, you could go with a 6 French. And then 6 French is exactly the profile of balloon septostomy sheet. So this, when I realized that, it basically made me thinking that this could be maybe used as an alternative of interatrial septal stenting in, for example, in some hypoplast babies, in some patients who need to have patency of the atrial septum for some time. And I will go more through that. So, what is Now, talking about small babies, the feasibility, safety, and efficacy of atrial flow regulator in children less than 10 kilos. We have published 4 cases, but we have done now more than that. Our publication, which is this year, included 4 children between 5 and 8.7 kilo, and the indication was the usual indication, just to offload the left atrium, either during ECMO support or to enlarge restricted interatrial septum in 2 other patients. So the device implanted were 6 and 8 millimeter, and we couldn't implant a 4 millimeter just because we didn't have available the device. And the device were successfully implanted. One baby developed a non-occlusive thrombus. I will come back to that. And there was clinical improvement in all the cases, really. This is the 4 cases. And I'm going to describe one of them. This baby with this 10-month-old baby with hypoplastic left heart syndrome variant. But all the other patients had uneventful procedure, and in all the cases at the beginning would just decrease the size of the sheet by 1 French, but for the 5 kilo baby, we decreased it by 2 French, and so we implanted 8 millimeter with a true 10 French, which is already a big in this at this weight. So the patient, the 5 kilo patient, this is a case. This is a patient who was born in Philippines. Birth weight was 2.4 kilo, and he had basically what I would call a variant of hypoplastic left heart syndrome, because in fact he had anatomy in double discordance, but there was a very small right ventricle. And then the left atrium was communicating with a very small right ventricle, and obviously there was no pathway there. It was a tricuspid atresia. And then the only pathway for the patient to maintain his cardiac output was through the PFO, and the PFO became more and more restrictive. So at the beginning, the patient was doing fine, and the plan was to do a PA band and go to the single ventricle pathway in Philippines. But then there was a storm. It's quite common to have storm in Philippines, unfortunately. But the baby was lost for follow-up and migrated to UK in January 2022. He was seen by a GP 1 month later, and because of the waiting list of the NHS, he was terribly blue, but he was only seen by us 3 months and basically 4 months after he came to the UK. So he had very poor growth, and he was 4.9 kilo with saturation in the 60s, very cynosed, and then this is his chest X-ray. You can see this is there is increased pulmonary blood flow, but this is post-capillary. This is the ECG as well, and this is the echocardiography. So as you can see, you have this left ventricle, and then you have a tiny PFO here. I think you can see that, right? And basically, the patient had suprasystemic PA pressure when we basically cut him. So what further management we would recommend in this type of situation? We just decided to do a cut and plan to increase the size of the atrial communication. So the cut here was showing very high pulmonary vascular resistance at 34 Wood units, and very high, obviously, pulmonary arterial pressure, 54 of mean PA pressure and 44 in the aorta. So it's quite desperate case, especially if you want to bring this case to a single ventricle pathway. And you see the restrictive PFO here. So we decided to first balloon dilate with a 8 millimeter cutting balloon, and then we implanted this 8 millimeter AFR, and importantly in this baby we always take the 5 millimeter height of the AFR, not the 10 millimeter, and this is implantation, so it worked very well. basically, and the patients improved dramatically. Saturation went to more than 90% of oxygen saturation, and you can see here the unrestricted flow through the AFR. And this AFR stayed patent. So we were in June or July, and a few weeks later, he put some weight, and we decided to cut him again. And then you see on the cut, you still have suprasystemic PA pressure, but then now on nitric oxide, you have baseline you have 10 of PVR, so they were 34. It's much better, but still QP over QS that is 0.4. But then when you give a nitric oxide, you have a much better hemodynamic. Much better hemodynamic profile with a QP over QS at 3.5 and plurivascular resistance at 1.5. So very reactive PVR. And then we had, it took us like 4 months to convince our surgeon to do a DKS plus a BT shunt, because you can imagine with this condition, with suprasystemic PA pressure, if you ask the surgeon to do that. But we did in October, and it went very well. Very well. Yeah, I have to say that he stayed in PICU for 2-3 weeks with a good dose of nitric oxide. But at the end, he had a good saturation, and this patient was successfully discharged. And unfortunately, 3 weeks ago, basically, he was ready for his GRAN, but 3 weeks ago, he passed away at home. We are still investigating what has happened, but basically, this was nothing to do with the AFR and with the surgery. By the way, the AFR was, of course, removed, and this is an important information for those who are considering to implant it. The surgeon could very easily pull out the AFR 6 months after we implanted it. So sometimes when you have to remove an ASD device, it can be very difficult surgically after months. But in this particular case, our surgeon had absolutely no difficulty to pull it out. And maybe it is because of the height of the AFR. So this is something that is an interesting information, because obviously, if as an alternative of stenting in a baby, you want to use that, you can say, well, don't worry, in 2-3 months, if you operate this baby, you shouldn't have any problem to remove the device. Anyway, we were encouraged by this experience, but we didn't have any more cases. So I discussed with my French colleague, and there has been now 3 additional cases around 5 kilo in France, and all of them were downsizes the sheet. So this is 5.2 kilo with a TGA VSD restrictive atrial septum. He had, pulmonary stenosis as well. This is why there was a PDA stent. And he had, like 3 weeks ago, a successful implantation of 18.6 AFR by Ali Wedji with one of my very good colleagues in Lille. And he didn't balloon dilate at all the septum before implanting the AFR, as I suggested him. And the patient is at home doing very well. He's waiting for his surgery. This other patient, similar patient, Alban Baruto in Nantes, at 5.5 kilo, he implanted 18.6 AFR. And then we had a problem because, so first he had to do septostomy, and then he balloon dilated the septostomy, and he implanted the AFR. And the AFR looked quite mobile, but and the patient went to complete AV block, well tolerated, but obviously after 10 minutes it was still in complete AV block, so he decided to remove the AFR. So maybe this is a bit better to have not to balloon dilate, because you will have the AFR that will definitely be nicely implanted, but maybe more stable in this type of patient with relatively thick but not too thick septum. This is an extraordinary case Sébastien Squet did in Paris. Neonate, he had myocardial infarction at birth, and he had basically complete ischemia of the left ventricle. I think it was probably a thromboembolic mechanism. So And he underwent. You see the left ventricle is clotted, is completely clotted, and the left atrium as well. So in this situation, he decided just to do the same management than for a hypoplast, and he did a PDA stent like that, and implanted AFR 18.6 also, that worked very well. So the baby is living in Mayotte, which is in an island in Indian Ocean. So he's back there, and now it's been 3-4 months, and he's doing okay. They did also bilateral PA banding as a systemic ventricle. So this is a single ventricle physiology. I don't know what is the future plan, but at least we know that the AFR has worked very well in this patient. And this is the last echo with, you can see the PDA stand. You can see that the left ventricle had somewhat recovered a little bit, and the AFR, 6 mm AFR, is working very well. The left ventricular thrombus has resolved, but not completely at the level of the left atrium. So basically, we have 4 patients between 5 and 5.7 kilo. Technically, the implantations were successful in all of them. There were 2 complications, 1 complete AV block in 1 patient, but hopefully it can be avoided. And our 5 kilo in London had IVC thrombus that resolved after 1 month under heparin. So the 4 patients, are doing fine, especially the 3 who have had the AFR. We know that the one in Brompton had the successful DKS, but unfortunately passed away after like more than 1 year after the implantation of the AFR. This is some data from the international registry, which is submitted at in Frontiers, hopefully soon published. And basically, those are the different type of indications. The main indication for this AFR registry remain like in adult patients with left heart failure, but also fenestrated phantom desaturation, right ventricular hypertension, patient on ECMO. It's interesting because basically 20 years ago, Zaid and myself, we were discussing about the indication of an fenestrated device, and we can see that in this international registry, those indications are unchanged, are still the same. And this is the conclusion of the International Pediatric Registry. 40 patients, 38 have been discharged alive, and 37 patients are alive at follow-up, despite sometimes very sick condition. So I think we can conclude that the implantation of the AFR is safe and effective in children. And then I think this is something that deserve to be considered in smaller babies because the profile is manageable, and possibly in babies we need more experience, but it could be an alternative in some babies over 3 kilo from the PDA, for the interatrial stenting. So, of course, we need more experience, but hopefully we will move forward to have more cases and bring additional interesting information. Thank you very much for your attention.